Hi, everybody. Welcome again. You're participating in the Medicaid Insights Colloquium. If you don't already know that, you now know. It's also known affectionately as the mic, and we're grateful to all of you for tuning in today. I'm Jamila Michener. I am a faculty member at Cornell University. I'm also co-director for Cornell Center for Health Equity and director of a variety of other things. But I think the most important thing about me is that I really care about Medicaid. I study it. And like all of us here today, spend a lot of my time thinking about how I can gain more knowledge and share more knowledge with others about Medicaid. So welcome, my fellow Medicaid geeks. That's what my children call me. And it's a term that I find endearing. We have a special panel presentation lined up for you all today. And I can tell that our topic is of great interest because, like I said, every time I look at the number of participants, it's going up and up. So it'll be really fun to get to share this information that'll be shared with you today. We're actually going to be hearing from the Medicaid Data Learning Network, also called the MDLN. So as many of you likely know, if you're tuning in, MDLN is a peer-to-peer learning network that's focused on using the National Medicaid Data Files, also known as the TAF data. The MDLN is managed by Academy Health. It's supported by the Commonwealth Fund and the Robert Wood Johnson Foundation, some of my favorite institutions right there. And it aims to accelerate use of this new exciting data resource. So we have several people here today who are going to share about the MDLN and their work with TAF. Among them are three researchers who should be pretty familiar to you all because they're a part of the kind of MIC committee, the MIC crew, and they're also heavily engaged in the MDLN. Okay. So you can see them up here on the screen, but I'll tell you a little bit about each of the people joining us today. Sarah Gordon is at Boston University at the School of Public Health there at BU, and she's co-director of BU's Medicaid Policy Lab. John McConnell is director of the Center for Health Systems Effectiveness at Oregon Health and Science University. And that's actually our host organization for this whole program for the colloquium. And then finally, among the MIC committee members, Will Chaparro is assistant professor in the Division of Health Policy and Economics of the Department of Population Health Sciences at the Joan and Sanford I. Weill Medical College of none other than Cornell University. So we have comprehensive representation from Cornell. Also joining us today, quite excitingly, is Susan Kennedy. So Susan is Senior Director of the Evidence Informed State Health Policy Institute at Academy Health. So Sarah is going to kick things off right now, and then we'll hear from the rest of the group. We're definitely going to be leaving time for discussion at the end. So please be putting your questions into the Q&A box as things go. So by the time we get to the end, we're ready to jump right into discussion. Okay, that's enough from me. Please join me in welcoming Sarah Gordon to the mic.
Thank you so much for that introduction. We are really excited to be here in this slightly different capacity than we typically are to talk about national Medicaid claims data and how it can be helpful in catalyzing impactful Medicaid policy research. Next slide, please. Actually, you can go one forward from here. Thank you. So to kick us off, here is a brief overview of what we are going to be covering today. We will start by introducing some of the challenges inherent in working with Medicaid data, what TMSIS TAF data are and how they advance the next generation of Medicaid data. We will then describe the Medicaid Data Learning Network and share what we have been up to for the past year, highlighting some of the central learnings from the experiences of the research teams that have been working with TAF. We'll then also review some of the studies that have been published so far using TAF. And then we'll close with some of our key takeaways and recommendations for the research community and for the data user community. And then hopefully we will have ample time at the end for questions and discussion. Next slide, please. So it is likely no secret to anyone who is attending this talk that conducting Medicaid research can be challenging due to a lack of high quality, comprehensive, and specifically national Medicaid data. Next slide, please. It's critically important that we invest and develop and enhance our Medicaid data infrastructure given the size and impact of the program. Medicaid covers over 93 million people and we spend a lot of money on it. Spending is projected to exceed $1 trillion for the first time in 2028. So complete, accurate, and timely Medicaid data are vital to conducting quality research that's policy relevant and enables the program to improve the health and well-being of beneficiaries. However, there are several reasons why Medicaid data has historically been challenging to aggregate. And one of these features is the federalist structure of the Medicaid program, which means basically that each Medicaid program is highly unique. It's run and governed locally to a large extent. And this extends to the ways that data and claims are collected and aggregated. So states have different processes for doing this that makes it difficult to synchronize data to a uniform, high-quality national data set. So these challenges have hindered Medicaid research, certainly in comparison to the volume and breadth of Medicare research, and also made it more difficult to engage in data-driven budgeting and policymaking within Medicaid programs. Next slide, please. So what are the TMSIS TAF? There's a lot of letters there. So basically all states submit data from their own internal systems called the Medicaid Management Information System. They submit this, they're required to submit this to CMS in this new format called the Transformed MSIS format. And then that raw data is then taken and developed into research optimized versions of TMSIS, of the raw claims that are received from states. And these are called the TAF RIF, or we'll just be referring to them as TAF, the analytic files. And so this is a sort of optimized version of the TMSIS. These data first became available, the TAF specifically, in 2014, though it wasn't until 2016 that all states were now moved over to TAF. So states adopted this variably between 2014 and 2016, and the data are available through 2021. The data are available via ResDAC at the University of Minnesota through a process of a CMS data use agreement, and there is unfortunately a significant cost associated with obtaining the Medicaid claims data. Next slide, please. So TAF data were released in 2019 and represent an important improvement in data quality over the prior generation of Medicaid claims, which is the Medicaid Analytic Extract, or MAX. And the other primary way that Medicaid research was conducted outside of MAX was to work directly with state Medicaid programs to obtain their data. And so often this would look like partnering with one state or maybe two states and conducting an analysis specifically using data that is a data use agreement between the research team and the state. So this can be a really valuable process. You learn a lot about from working directly with a state. However, it is much less generalizable because you are limited to just working sort of on a one-off basis. So the TAF represents an important contribution in terms of national aggregate Medicaid data availability. And compared to MAX, the prior generation of Medicaid data, TAF includes additional file types, far more data elements, including more granular data related to managed care, waivers, and demonstration programs, a monthly rather than a quarterly submission schedule, enhanced data quality resources, including the Data Quality Atlas, or the DQ Atlas, which we'll talk more about in a bit, and also a slightly different responsibility of data quality, moving from the federal level to the state level. So states are more responsible for the quality of data, whereas with MACs, there were sort of extensive validation and data quality procedures that happened at the federal level. So despite these enhancements, the TAF data remain highly complex, which poses challenges for the Medicaid research community. Next slide, please. So what exactly do the TAF contain? So there are several different file types. I list the 4 main file types here. Researchers can obtain all 4, or they can purchase only a subset of the 4. There is an inpatient file that includes data on inpatient hospital claims. There is a long-term care file, which includes service data on nursing facilities, intermediate care facilities for individuals with intellectual disabilities, mental health facilities, and independent psych wings. The pharmacy data include drug data and data on services provided by pharmacies. The other services file includes a lot of data on outpatient services and physician services. It's basically a catch-all file for all claims, encounters, and payments that are not captured in the other files. And there's also 2 supplemental files, the annual managed care plan file, which includes characteristics, population enrolled, service areas, et cetera, of managed care plans that operate in Medicaid, and also an annual provider file, which includes information regarding the characteristics, provider taxonomies, location, licensing, accreditation, et cetera, for providers participating in Medicaid as well. Next slide, please. So what kind of exciting research questions can we ask using TAF? So this is by no means a comprehensive list, but we just wanted to give sort of a sense of the different types of things that can be done with this data. And we'll provide more examples of things that have actually been published so far. But we can describe inpatient, outpatient, prescription drug, and long-term care health service utilization. We can measure spending at various levels of aggregation, so per capita, by population, by state. We can construct claims-derived health outcomes. To a certain extent, we can measure differences in outcomes by race, ethnicity, eligibility category, age, sex, and geography. We can evaluate the effects of state-level Medicaid policies by comparing across states and over time. We can examine quite granular patterns of Medicaid enrollment, including tracking people as they move across state lines. We can assess metrics of access to care and quality of health services. And we can also assess provider participation and look at the role of managed care. Next slide, please. So before I pass it over to Susan, I just wanted to say a little bit about how the Medicaid Data Learning Network came to be. So I think when Will, John, and I started working with the TAF on our respective projects several years ago, I think we all had sort of the same moment of realization of just how many decision points there were. And given the fact that there were still so many remaining issues with the data, we didn't want to be making these decisions in a vacuum and to have sort of every research team taking a different approach with different justifications and creating a lot of complexity. So we were looking for a way to convene people who were pioneering with this data, get them together in a room or a virtual room with the goal of creating consensus, providing feedback to each other, and to the extent possible, generating some standards for how to be good stewards of these data, how to use the data meaningfully, and to make sure that the information from TAF that's used to inform policy and ultimately affect lives is as accurate and high quality as we can possibly make it. So we then had the good fortune of being able to partner with Academy Health to be the host home for our learning network and to be the convener of all of the research teams to share best practices from their experiences working with TAF. So with that, I'm going to now pass it off to Susan Kennedy at Academy Health, who has been such a fantastic partner in this effort.
Thank you very much, Sarah. And it's so nice to be with all of you today and to see how excited everybody is to learn more about our learning network. So as Sarah said, in an effort to really increase transparency, harness collective expertise, and improve the quality of Medicaid research using TAF, with support from the Commonwealth Fund and RWJ, we developed a learning network of research teams currently conducting research using TAF. So a little bit about the network, its goals, structure, and composition. Next slide. Thank you. So the goals of the network really are to create a forum for TAF researchers to share their collective expertise, as I mentioned, and their approaches that have been gained from working with the data set. I'll share a little bit more about the composition of the learning network in a few slides. We also aim to achieve consensus on best practices for key TAF methods and ensure that the shared learnings with the broader health services research community, which is, as many of you know, with Academy Health is very important. Also, in doing so, the network aims to provide greater opportunities for those health service researchers to use Medicaid claims and increase the number of those researchers focused on Medicaid-specific research. And equally important, we aim to share these learnings back to CMS and state Medicaid agencies and their analytic partners with the goal to improve the quality of TAF data over time. Next slide. So in the first year of the network, which we just completed, we hosted 9 learning sessions, with the first being hosted in person to kick off the network and allow members to share their challenges and desired or envisioned topics to address over the year's curriculum. The following 8 learning sessions were then informed by the initial meeting, were then hosted virtually and showcased expert presentations, a question and answer period, and focused breakouts to enable more detailed discussions on methodological approaches. Now, these learning session topics you see here included reviewing the limitation of using TAF's race and ethnicity data, methods for analyzing maternal and reproductive health research, and developing a key checklist for researchers to reference when using TAF in their research. Next slide. So here's a list of the network's Year 1 members, comprised of academic institutions with researchers actively working with TAF. Now, for the first year, we requested teams limit participation to 3 researchers to ensure active participation so that we could actually collate those learnings. Next slide. Now, along with those members, we had an advisory group who represented key perspectives and guidance, including the intentional involvement of CMS and their TMSIS contractor, Mathematica, to ensure bidirectional learning. Okay, next slide. And hopefully I will turn this over to John.
Yeah, thanks, Susan. So as Susan mentioned, we've had 9 sessions that have covered a variety of topics, and we wanted to take some time today to highlight findings around 3 topics, and those include utilization, spending, and data on race and ethnicity. Next slide, please. A lot of you are probably interested in understanding measures of utilization, number of primary care visits, prenatal visits, emergency department visits, hospitalizations, rehospitalizations, lots of good stuff there that's fodder for research. It's really important to remember that the TAF data include fee-for-service claims and data from managed care organizations. The fee-for-service data are fairly straightforward. Each visit results in a claim that serves as the basis for providers' payment. The managed care data are more complex, and so you might imagine that a primary care physician gets a capitated payment from a managed care organization, and upon seeing a patient for multiple visits, why would they record that? Because they're not going to get paid more or less depending on the number of visits that a patient makes. But in most cases, those visits do show up as encounter claims, and this records utilization, and the encounter claims are fairly reliable. So there are a lot of incentives to record those data because they're used as the basis for rate setting. So we feel that generally these do a good job of capturing utilization. Nonetheless, not everything is coded in the same way. Some things are fairly reliable. Primary care visits generally look the same across states and managed care organizations, but other things like ambulance visits can vary a lot. And so sometimes they get paid on a per transport basis. Sometimes they get paid on a per mile basis. There's other configurations. And so you have to be careful if you just start counting number of claims or number of things you think are visits or episodes. It's not always the same for some of these services. Many of you might also have an interest in identifying provider specialty or attributing patients into a clinic. There's a lot of really wonderful Medicare studies that have used this approach, but it happens to be more challenging when using Medicaid data. There's some variability in the quality of the taxonomy fields and how they're coded across states, and there's nothing like the TINs or tax identification numbers that exist in Medicare data, where it's a little bit easier to group physicians into a clinic. Next slide, please. If you do want to conduct a study of utilization, we have a few suggestions. So your first stop is the DQ Atlas. And so this is an online resource that has been developed by Mathematica. And the DQ Atlas is a great way to understand a starting place of your data. And so you might find, and so this will tell you which states have good quality data for the fields you're interested in and which have data that are of more concern. Second, we suggest that you use an internal benchmark and not just rely on the DQ Atlas. So for example, the DQ Atlas might say that the data quality are good for, say, Florida. But when you look at your outcome of interest, perhaps that's primary care visits, you might find that visit rates for Florida are 50% below the median. And that might be too low to be plausible. You might think that some of this is natural variation, but there might be some benchmarks or thresholds where you feel like it's not a data quality, it's not actual service utilization variation, but the quality of the data is a problem. You can also use external benchmarks. And so Sarah Gordon has a paper on severe maternal morbidity. They wanted to understand how reliable the TAF data were in terms of counts of live births. And so they benchmarked that according to some data from the CDC that they had to validate their study and understand how to validate the states they're using in their study. We also recommend using common definitions of utilization measures where possible. So there's a lot of common measures for primary care visits, emergency department visits. And if you develop your own homegrown measure, it may be hard to do benchmarking to other studies. And so if you see differences, it may be hard to disentangle whether that's a coding difference or a data difference. There's some other exclusions that you want to consider when using Medicaid data. For example, unless you have linked Medicare data, you will probably want to exclude dual eligibles because a lot of their utilization shows up in the Medicare data. And if you're just looking in Medicare data, if you're just looking at Medicaid data for the duals, you will be missing a lot of utilization. If you're trying to identify provider specialty, you'll probably want to use other data such as MedPass or information from the claims to ensure that as you develop, as for example, a panel of psychiatrists, that the types of utilization you're seeing for that panel of psychiatrists looks like mental health care and not something else. Next slide, please. Moving on, spending is another area that's probably of great interest to a lot of you here, but studying spending or expenditures presents some large and perhaps unique challenges in Medicaid data. The fee-for-service data are generally fine, but managed care data are not great, and this is a problem. Managed care is a really important part of Medicaid. It covers more than 70% of Medicaid beneficiaries. I mentioned that utilization occurs through the encounter data, and we feel that those are pretty reliable, but the encounter data typically don't have any paid amounts on them. And so when you look at those fields, they'll be missing or will have zero amounts. And in some cases, they might have price data, but a review by the Office of the Inspector General suggested that even when those data appear, that they're not reliable. In addition to the regular claims data, there are a variety of other payments that occur in Medicaid supplemental claims, but they are probably underreported. So some real challenges here. Next slide, please. And unfortunately, the solutions for measuring spending are not as comprehensive as they are for utilization. To start with, it's helpful to know that there are some reports. These are called CMS 64 reports that can be used to assess total state spending. And so you can use these as a benchmark. And so, for example, if you did make some efforts to roll up expenditures and try to look at them across states, you could use these as benchmarking, and you might find that in some cases you're lucky that whatever you're doing to address expenditures gets pretty close to the CMS 64 reports, and those would probably be pretty good for states that have mostly fee-for-service, but probably more challenging for states that have a lot of managed care, and you might find that you have more missing data there. You can also do some work to impute prices. And so just to kind of spell this out, you could imagine taking a common procedure code like 99213, that's a pretty common primary care code, and doing some data management. So you remove all the zero and missing amounts and take the median amount that's there, perhaps a national or state median, and then filling that in for all the claims there. So you have one price, or maybe one price that differs by states, or maybe you just use a national median. There's a lot of studies out there that have done that type of thing. We think that works fairly well for common services, primary care, emergency departments, but it gets trickier for things like hospitalization, which might be paid on a DRG basis. In some places, percent of charges per diem can really vary a lot, or transportation that has some of the issues that I mentioned before. Next slide, please. Race and ethnicity data are collected via self-report from enrollees, but this is not mandatory, leading to a lot of variation in data completeness across states. Definitely not ideal. Medicaid can be a really powerful lever for advancing health equity, but without those data, we can't say much about the size and scope of existing disparities or where we're seeing progress or maybe slipping back. Next slide, please. This is a slide from 2019 data with Mathematica's DQ Atlas, and states that are green are low concern, not a lot of issues with data quality. Yellow is medium concern, but we see a lot of orange or red here, which is high concern or unusable. Next slide. If you do want to use race and ethnicity data, these are our suggestions. First, we think you might want to decide on your own benchmark what's appropriate for amount of missing, and that may give you, let you add some states that might be ruled out if you just sort of took a broad approach that's presented in the DQ Atlas. You can, of course, you restrict your analysis to the subset of states with good data. You may also find that missingness is not so bad for your particular study group. And so it might be that DQ Atlas list data quality is a high concern for the general population, but when you dig in, maybe you're looking at children or pregnant people, you might find that missingness is quite low and you might feel comfortable using those. If you have longitudinal data, you can do some work to do some imputation. So you might find that that for some of your enrollees, race and ethnicity data are missing in one year, but they exist in the other year. And so you can use some of those extra years to fill in where it happens to be missing. And then finally, we expect that at some point, CMS will release a file that imputes race and ethnicity when it is missing. They're using a method called Bayesian imputed first name, surname, and geocoding, or BIFSG. That is a successor to BizG, which just left out the first name. And I won't go into the details here, but there's a variety of publications that use BizG, show you what it looks like and how reliable it is. So you can get a sense of what that methodology is. So next slide here, I'm going to pass it on to Will to discuss some research examples.
Thanks so much, John, and thanks everyone for joining us today. Next slide, please. So since the advent of TAF, its first release to the public in 2019, we've seen, year-over-year increases in the number of publications leveraging these data to answer policy relevant questions. By our count, there are about 20 publications so far, and I think in large part, this is a good number, but also a number that reflects how complex these data are. I can say my own personal experience, we've just submitted our first papers leveraging these data. It's taken a long time to get comfortable that we have addressed all of the potential data quality concerns that might impact our analyses and our interpretation of our analysis. Next slide, please. So I think TAF has clearly catalyzed policy relevant research in Medicaid. And of note, when you look across those first 20 or so publications, almost all of them focus on really timely policy issues. So a number focus on issues around maternal and reproductive health in the context of the US's current maternal mortality crisis, where Medicaid policy has and will continue to play a very important role. A number of papers focused on Medicaid policy for mental health care, for the treatment of substance use disorders, and for thinking about health equity, both health equity within Medicaid, as well as more nationally, how Medicaid can be an important policy lever for improving health equity. I would say there are probably fewer papers at this point focused on leveraging TAF to answer questions in the long-term care space, where perhaps the CMS minimum data set might, for certain questions, be a better option. We've also seen, I think, relatively few papers focus on Medicaid managed care leveraging TAF. And this, I think, in large part is because for certain types of questions or research designs, that is a space where state-specific claims data may be more useful. I think it's also worth highlighting that most work to date has been descriptive, establishing, I think, really policy relevant, first order descriptive evidence on the state of Medicaid rather than causal, rather than, leveraging natural experiments to estimate causal effects. And this is where I think there are lots of opportunities in TAF, whether it be, as Sarah mentioned at the outset, leveraging policy variation across states in the context of a difference in differences framework, whether it be leveraging discontinuities and eligibility. In TAF, we have access to imperfect, but access to income data that can be used to estimate effects at certain discontinuities that might impact access to certain benefits in Medicaid. You can track folks as they move within states or across states. That can allow for a mover type design to estimate the effects of receiving care within different types of healthcare delivery systems or within different states. So I think lots of opportunities to move from descriptive to causal evidence to inform Medicaid policy. We're now going to turn to highlighting, I think, 4 really representative examples of policy relevant research that can be conducted using TAF. First, one paper that focuses on utilization, then one on spending, and then lastly, two that focus on health equity. We'll begin here with a paper focused on utilization by John and his group.
Yeah, so this is as Will said, just a very simple descriptive study. And so we're looking at regional variations in emergency department visits for mental health conditions. We're interested in that measure because Medicaid is the biggest payer for mental health services. And you could argue that emergency department visits for mental health are a proxy for access to mental health care. For example, if there was really wonderful access for ambulatory mental health care, you would anticipate that emergency department utilization for those conditions would be fairly low. So we looked at rates of these visits by state economic areas, which is a geographical area that groups counties together within states. And we found a really wide variation across those regions, across and within states. Relatively low rates in Colorado, West Virginia, and Arizona, relatively high rates in Ohio, Nevada, and Iowa. As Will noted, this is just a descriptive study, but this is a great place to start given how little we know about mental health services in Medicaid, and kind of begins to ask some questions as what's happening in those high utilization states, and that's sort of our next step in research. Well,
great, thanks, John. Next slide, please. So this next example focuses on spending. One of the few papers to be published leveraging TAF to measure spending in Medicaid. This is by Zach Cooper, Becky Steger, and colleagues. And this paper really is an effort to extend Dartmouth-style analyses of regional variation in spending and utilization from Medicare and then the private markets to Medicaid. And so this paper compares regional variation in spending across those three different payer categories, uses specifically 2016 and 17 data from TAF. And I think, as a function of its federalist structure, perhaps not surprisingly, Medicaid from this paper had the highest variation in per capita spending across regions. Notably, there were just 3 HRRs that were in the lowest quintile of spending across all 3 insurance programs. And there were few area level correlates of spending that were consistent across all 3 papers. So an important first look at understanding regional variation in spending and utilization in the Medicaid program. Next slide, please. And this next paper focuses on understanding disparities in the maternal health context. And this is by Sarah and some of her colleagues. Sarah, I'll turn it to you.
Sure. Yeah, so this is from a study we did using TAF where we examined severe maternal morbidity, which is a maternal health indicator of an adverse health event. And we decomposed the leading causes of severe maternal morbidity by state and by group, stratifying by non-Hispanic Black and non-Hispanic White. So in this figure, the left side panel is the non-Hispanic Black panel, and the right side panel is the non-Hispanic White panel. With respect to individual indicators of this composite severe maternal morbidity measure, eclampsia was the leading indicator overall in 31 states and the leading indicator among the non-Hispanic Black population. And in contrast, sepsis was the leading indicator in 4 states and among the non-Hispanic White population. So as you can see in these maps, some states are concordant in terms of the leading indicators across racial groups, while others are not, such as California, Utah, New Mexico, Maine, Florida. So our hope is that by decomposing and showing these differences and really drilling down by geography and by racial group, it can help tailor resources and interventions to the specific conditions that are driving maternal morbidity among Medicaid patients in a given area. And then our hope would be that a next step to build on this work would be to use these types of outcomes to evaluate the effects of interventions and policies that are being implemented in the maternal health space by comparing across states.
Great, thanks so much, Sarah. Next slide, please. The last paper we wanted to highlight is this one by Laura Smith and colleagues at the Urban Institute. And in this paper, the authors used TAF combined with other data, most notably from the census, to examine the association between racialized economic segregation and preventable hospitalization among kids in Medicaid and CHIP. And they found that after adjusting for a variety of individual level covariates, children living in zip codes that had the highest concentration of low-income, non-Hispanic Black residents had adjusted rates of preventable hospitalizations that were considerably higher on a per capita basis than children living in zip codes that had the highest concentration of high-income, non-Hispanic white residents. This was primarily driven by hospitalizations for asthma-related exacerbations. And I think the main takeaway here is that Medicaid-enrolled children's risk of preventable hospitalizations really depends on where they live. And there's an important role here for Medicaid to play in improving access to preventable health care to reduce rates of these hospitalizations. I think this work can also inform broader public health interventions to reduce hospitalizations due to asthma. Next slide, please. So we've learned a lot in this first year of the MDLN, and I know a lot of MDLN members are on the phone with us today, and I want to begin by really saying how everything we've learned is a function of the incredible collaboration among these 11 research teams. Each learning session, teams have come prepared to share their experiences in working with these data. And so the work that the findings that we've shown you today and walked through today really are a function of that collective sharing that we think is a really nice example of collaboration in applied policy research in academia. Next slide, please. So I think from this work, we in the MDLN have identified a number of important takeaways for researchers who seek to use TAF to inform Medicaid policy. As John mentioned, we think TAF are really well set up to engage in studies of utilization, whether it be utilization among enrollees in fee-for-service Medicaid or in Medicaid managed care. That being said, I think we would doubt that there is any research question, any outcome where data are of sufficient quality to allow for analysis across all 50 states, DC, and territories. And so any analysis in TAF, including those that seek to measure utilization, I think benefit from leveraging a variety of external resources, most notably the DQ Atlas, to think about in what states data are of sufficient quality given the population and variables of interest to answer the question credibly. And I think lots of thoughtful work is needed to ensure that the analysis is conducted on a sample that is of sufficiently high quality for the question at hand. Studies of spending are feasible, but it really depends on what type of spending you're talking about. The paper by Zach Cooper and colleagues shows, I think, that it is possible to measure spending sort of from the state perspective, looking at global spending per beneficiary. But if you're trying to measure service-specific spending, where you need the spending on, specific encounters in managed care, that's where things get more challenging. As John mentioned, payments on encounter records reflecting visits for managed care enrollees, it's the paid amount from plans to providers, those are redacted. They're considered proprietary data. And even the unredacted data, according to the HHS Office of the Inspector General, are of low quality. And so if you want to include that type of spending in your analysis, you need to engage in some imputation that might lead to some measurement error. We didn't talk about this today, but between MACS and TAF, we now have a very long time series of national Medicaid claims data. And because there was a significant change in data structure in that transition from MACS to TAF, there needs to be a lot of careful thought given to those analyses and a lot of careful work to test for any sort of anomalous changes in the distribution of key variables as states made that transition from MACS to TAF, recognizing that there was variation when that occurred across states. The first states made that shift in 2014, and then the last states made that shift in 2016. And then lastly, I think a lot of us are interested in using these data to inform how Medicaid can play a role in improving health equity in the US. And we know that there is a decent amount of missingness in the demographic data included in TAF, most notably including the race and ethnicity data. And so this is a case, as John said again, where we have I think, good solutions to make the data more usable than they are in the raw files, to impute across years, to limit to subpopulations where data quality is perhaps higher. But again, this is a case where if you're interested in understanding disparities within Medicaid, it's unlikely that in TAF you could examine those disparities across all 50 states. Next slide, please. One of the key goals of the MDLN is to provide feedback to CMS and state Medicaid policymakers in an effort to improve these data going forward. And so we have, out of this first year, really 3 key recommendations. One goes to the point I just made. We really do need to work to improve missingness in demographic information in these data. As John mentioned, when it comes to race and ethnicity data, states by law cannot mandate the reporting of those data by enrollees, but we do know there are a variety of evidence-based approaches that states can take in terms of how they frame those questions and that make clear how the data that will be used that can improve reporting rates. And so we really do encourage CMS and its contractors to continue to work with states on implementing those evidence-based practices to improve the quality of race and ethnicity data in TAF, along with other demographic information. Secondly, we really do think steps need to be taken to improve the transparency of managed care data in TAF. Over 70% of Medicaid enrollees are now in some form of managed care. As we mentioned a few times now, payments from plans to providers are redacted. The underlying unredacted data are not of particularly high quality. We really do think CMS should work with states to improve the quality of those data and should unredact them. In many state-specific claims data sets, those numbers are often available. And so we do think there is precedent here that they should not be treated as proprietary, and public release really is in the interest of improving oversight of the Medicaid program. And then lastly, we think that CMS should take really meaningful steps to improve the accessibility of the data files. CMS should reduce the cost of purchasing TAF data. Depending on how you access the data, that cost can range anywhere from $30,000 to $65,000 per year of data. CMS should reduce the fees associated with refreshing the data. TAF files are often updated, reflecting corrections or newer, refreshed data from states. CMS often charges fees to refresh the data, which means many researchers are working with data sets that are not as high quality as they should be. And then lastly, we think CMS can take steps to improve the transparency and documentation of TAF data releases and improvements to the data over time. It's nice to see that since the first release of TAF, a variety of new data elements have become available. We think there can be more done to improve documentation around those changes. Next slide, please. We're really looking forward to year 2 of the MDLN. We just had an open call for new teams to join, and we're excited to say that we're tripling the size of the MDLN. We're going from 11 up to about 34 teams. There are a couple of teams that we think will be joining that are not reflected here. But this gives a sense, I think, of the broad diversity of the types of organizations that we're excited to include in the MDLN in its second year. Next slide, please. And then looking forward, we're excited to continue these learning sessions for members where we're hoping to sort of share best practices and have sort of therapy sessions around working with TAF in an intimate environment. But we also want to continue to sort of democratize access to these data and to these best practices. And so we'll be alternating these monthly learning sessions with public webinars going forward. We're also excited to have 2 public products that we hope to release this coming academic year. One is what we're calling a TAF research checklist. Think about this as being analogous to STROBE for observational studies. This is a checklist for researchers working with TAF, a set of very basic things that we think TAF researchers should report when they submit research derived from TAF data to a journal, and that journal reviewers and editors can use to ensure that the work that we're conducting is transparent and reproducible and as high quality as possible. We also hope to release a more detailed methodological report that will have additional coding resources to hopefully standardize, really common things all of us who use TAF likely will be doing, for example, defining comparable eligibility categories across states. Next slide, please. And I'll close by saying, if you want to learn more, a few things to highlight. First, the recording from this session will be available on the Mike website, I think in just a few days. If you came in late, you can go ahead and grab that later on. The first link here on the left is to our year one summary report from the MDLN that summarizes key learnings from each of the 8 learning sessions we held this year. So that's available on the Academy Health website now. We have a link here to Mathematica's DQ Atlas. This is the phenomenal data product that John mentioned that Mathematica has produced under contract with CMS that provides really, really detailed information across years and states on the quality of almost every data element in TAF you could care about. And so really is a key resource for thinking about, for a given research question, what is the approximate sample of states that look like they would be sufficiently high quality to answer that question credibly. Sarah, John, and I also have a blog post that went live today on the Commonwealth Fund website. That's the third link here. And this summarizes our key recommendations to CMS on ways that TAF data and the accessibility of the data can be improved going forward to further catalyze policy relevant research in Medicaid. And then lastly, if you want to keep engaged with the MDLN, we encourage you to join our listserv, and that's the last link there on the right. I should mention, if somehow you didn't get these links right now, we'll also be sending out an email after this session to all attendees that has these links. Next slide, please. So we're going to pause our deck there and now open it up to questions. Jamila, I'll turn it back to you to guide us through that.
All right. Thanks, Will and team. That was a tour de force, and I was learning as we went. So I appreciate what you all shared. Those were great presentations, and it's really exciting to see how we can work with this new data. So I'm sure that we all have ideas and things that we want to talk about. So I'm going to bring the full group back now, and we're going to open up discussion so that we can jump right into the questions that you all have submitted. So there are now quite a few questions, so we'll just do the best we can. One thing I'll say before diving into some of the specific questions is that there are a few questions about whether the slides will be available. And so those are easy to answer. We'll be sure to get those to you after this so that you all can have them as a resource to the extent that you would like to. So no worries about that. All right. So the first question, the first brave person who offered a question was Joe Benitez, our next Mike speaker, actually, which I'll mention later. And Joe asked whether the TAF allows researchers to distinguish enrollees in different MCOs, and just points out how this might be really useful to investigators interested in doing research that's relevant to that. So wonder if one of you might tackle that.
Yeah, I'm happy to start, and then maybe John and Sarah, feel free to add in anything I've neglected to mention. So it's a great question. And, I think, as I said in my section of the presentation, this is super important, right? Most folks in Medicaid are now in some form of managed care. There are lots of important questions around how managed care is affected: utilization, access to care, quality, outcomes, et cetera. The short answer is yes. So from the TAF demographic and eligibility file, we know what managed care plans, and plural, because you can be enrolled in multiple plans at once that cover different types of things, someone is in basically each month of the year. And then in addition to that, there is this supplemental managed care plan file that includes, as Sarah said, pretty granular information on plan level characteristics. That being said, as a few of us mentioned, there's not been a lot of in-depth work leveraging those data elements to date. And so I do think there is additional work needed to sort of validate some of those data elements. But theoretically, yes, the data are there that can allow for TAF to be used to examine variation in different outcomes across plans or within plans. John, Sarah, anything I missed there?
That's good.
Great.
Awesome. Good, because we have more questions. So a few of the questions are about specific populations and leveraging the TAF data to try to understand those populations better. So we have a question about the TAF data in relation to disabled populations, and another about the TAF data in relation to race and ethnicity. And that one is specifically about whether those data are getting better over time. So maybe we can do a 2-for-1 and just talk about those two populations for a bit and using the TAF data to try to study them.
I can take the second piece. At least according to DQ Atlas, it looks like the general trend is that the race and ethnicity data are improving in quality over time, but it is not always the case. You will see some states that do move from, for example, in 2017, having low concern data, and then in 2018 they have medium or high concern data. It's not entirely clear why that's the case, although we do know that states do review their data, and that is reflected in subsequent releases, which sometimes changes the data quality. And this is why one of our recommendations was around increased transparency around new releases and making sure that it's very clear what's changed from release to release, because it's not always just improvements. States are doing historical revisions of their data, which may also result in a decline in data quality, which can be very frustrating for researchers because it's difficult to optimize which release you want to choose. So if you were specifically interested, my advice would be, if you were specifically interested in looking at different racial and ethnic groups, I would actually use the DQ Atlas to choose your states, your years, and your releases strategically to make sure that you're maximizing the highest quality data.
Yeah, and I'll add a little bit to that. I think, another way to think about this is sort of the race to better quality data. Some of that may be improvements from states, and another piece that may come is this this file where there's going to be imputed race from CMS. That's less than perfect, but may arrive sooner than kind of full 50 state completeness. So that's one way to think about this. With respect to research on the disabled population, I don't know if I've got great insights there other than they've been included in studies that we have. Eligibility because of disability is in the TAF data, but that's probably about as much as I've got to say on that issue from my own experience.
All right, well, maybe we have time for one more question, and apologies to all of the people whose questions we won't get to. But these questions are excellent. There are a few questions about how to get involved, whether graduate students can get involved, whether particular institutions are involved. And so maybe in the materials that we send you after this, we'll just kind of clarify some of those details. That way, those of you who are looking for that kind of detail can get it. So let's see, we have a question here about the linkage between max and TAF at the individual level if the same individual crosses files, which is something that it's not the first time I've heard a question like that, so I thought that might be an interesting one for us to surface.
I'm happy to start. So in theory, I will say we had a fantastic session on this in our learning network. We had a representative from CMS come because this was like the #1 question people had: can we link max and TAF? The answer was, in theory, yes, that the IDs should work across the two generations of Medicaid data. However, there are certain groups for whom it might not be perfect. And we did hear from teams who were actively trying to do this, that in practice, it was not always successful. So I think it's sort of like, the message was a bit like, do this at your own risk and be very transparent about any discontinuities you see as the data transition from max to TAF, but that in theory it should be possible. But because of a lot of those differences that I mentioned, and just in terms of the number of data elements, the file structures, et cetera, there might be other issues when you start constructing outcome variables and you start trying to actually measure things where you might see issues. But the question on the ID specifically, it should be linkable for the vast majority of beneficiaries.
All right. Well, lots of other questions here about details like that have to do with linking data. And and also questions about linking to various kinds of state data. And so it's great to see this thinking around how to utilize this data in the most kind of creative and innovative ways possible, and to maximize its use with other kinds of data. So, okay, we have to move towards wrapping up here, and I'm sorry that we won't get to answer more of your questions, but luckily MDLN is a continuing resource that you now know about, and not only will we share information with you because you've been here and we have your information and can reach out to you, but also you know about this resource and hopefully know much more than you did before. Okay.
I will also just add that I saw several questions that are actually referenced are touched upon in our summary report. So when you get that email, if you check that out, we have a whole section on linking Max and TAF where we summarize a lot of this stuff. There's a whole section on race and ethnicity. So just a plug to go read the longer version, the much more nitty-gritty version than this talk today.
That's perfect. It's great to be able to have more resources to turn to for those of you who have questions remaining. So that's awesome. Thanks, everyone. This has been a great discussion. And it's been wonderful to have all of you who are in the audience here today and to have participated in the discussion in the ways that you have. So I have just a few closing words. First of all, you're going to be receiving a 2-question survey about this session in your email, and that just helps us to continue to make these sessions more useful to you and to continue to improve. So as researchers, we know how important it is to have high return rates on our surveys. So please respond to that if you get a moment. The next mic session is going to be on Wednesday, August 30th. You can see here from the slide that's up that the next mic drop is going to feature none other than Dr. Joseph Benitez from the University of Kentucky. And Dr. Benitez is going to share his researches about changes in the composition of the Medicaid population. So we're going to have RSVPs open soon. Don't forget to sign up. And also to sign up for updates by joining the Mike community at the series website, which is pretty straightforwardly MedicaidInsightsColloquium.com. And if you do that, then you will never be out of touch with the latest Mike updates, and we'll get to continue to learn with each other and from each other. And our next opportunity to do that will be August 30th. So looking forward to seeing you all then. Thank you for being here today. We are done. That's a wrap. And here you go. You have not only a thank you slide, but you know who to reach out to with questions and comments. And certainly from looking at the Q&A, we had lots of those. So have a good day, everyone.